Which physiological parameter is most improved by using hemofiltration to achieve a negative fluid balance in a VV-ECMO patient? A. Right ventricular afterload. B. Alveolar arterial, AA, oxygen gradient. C. Systemic vascular resistance, SVR. D. Cerebral perfusion pressure. Answer: B. Alveolar arterial, AA, oxygen gradient. Explanation: by removing excess lung water, pulmonary edema. Hemofiltration improves gas exchange across the alveolar membrane, thereby reducing the AA gradient and facilitating weaning from the oxygenator. A patient on VA-ECMO develops SIRS-like symptoms with profound vasoplegia. Why might high-volume hemofiltration be indicated here? A. To increase the viscosity of the blood. B. To filter out anaphylatoxins and middle-molecule inflammatory mediators. C. To provide a source of exogenous bicarbonate. D. To increase the temperature of the blood. Answer: B. To filter out anaphylatoxins and middle-molecule inflammatory mediators. Explanation: high-volume hemofiltration, HVHF, is sometimes indicated in the setting of ECMO-induced or sepsis-induced systemic inflammation to clear cytokines, e.g., IL-6, TNF-alpha, although clinical evidence on survival benefit is still evolving. What is the primary indication for integrating CRRT directly into the ECMO circuit rather than using a separate venous access? A. To prevent the need for additional anticoagulation. B. To avoid additional invasive vascular access and associated infection risks. C. To ensure the CRRT pump runs faster than the ECMO pump. D. To prevent the ECMO oxygenator from clotting. Answer: B. To avoid additional invasive vascular access and associated infection risks. Explanation: using the existing ECMO circuit access points avoids the need for a separate large-bore dialysis catheter, VAS-CAF, which reduces the risk of line-associated bloodstream infections, CLABSI, and vascular trauma in a heparinized patient. In the setting of early versus late initiation, which scenario indicates early hemofiltration to prevent ECMO circuit complications? A. To manage hypercalcemia. B. To prevent sludging in the oxygenator by maintaining lower hematocrit. C. To manage severe fluid overload before it causes significant lymphedema at the cannulation site. D. To treat hypernatremia. Answer: C. To manage severe fluid overload before it causes significant lymphedema at the cannulation site. Explanation: severe peripheral edema can compromise lymph perfusion and make the cannulation sites prone to breakdown or infection. Early fluid management via CRRT helps preserve tissue integrity. Which of the following is a contraindication to starting hemofiltration via the ECMO circuit? A. Patient weight less than 10 kilograms. B. Active bleeding requiring massive transfusion. C. Extremely low ECMO flow rates, e.g., less than 1 liter per minute. D. Presence of a membrane oxygenator. Answer: C. Extremely low ECMO flow rates, e.g., less than 1 liter per minute. Explanation: at very low ECMO flows, often during weaning, the shunting of blood through the CRRT machine can significantly reduce the flow returning to the patient or cause pressure instability within the ECMO circuit. When a patient on ECMO has an indication for hemofiltration due to tumor lysis syndrome, what is the primary goal? A. Removal of uric acid and phosphate. B. Increase in serum potassium. C. Reduction of the white blood cell count. D. Cooling of the patient. Answer: A. Removal of uric acid and phosphate. Explanation: ECMO patients with hematological malignancies can develop TLS. Emergent hemofiltration is indicated to prevent the crystallization of uric acid in the renal tubules and to manage life-threatening hyperphosphatemia. How does the indication for ultrafiltration change when a VA-ECMO patient develops left ventricular, LV, distension? A. It is used to increase the preload to the LV. B. It is used to reduce total blood volume and decrease LV filling pressures. C. It is used to increase systemic blood pressure. D. It is used to increase the heart rate. Answer: B. It is used to reduce total blood volume and decrease LV filling pressures. Explanation. Fluid removal via hemofiltration is a key strategy to unload the LV, reducing wall stress and pulmonary venous congestion, which is critical for myocardial recovery. Which acid-base disturbance is an indication for CRRT in an ECMO patient with a failing liver? A. Respiratory acidosis. B. Metabolic alkalosis from citrate anticoagulation. C. Lactic acidosis. D. Hypochloremic alkalosis. Answer: C. Lactic acidosis. Explanation. In patients with combined liver and kidney failure on ECMO, CRRT is indicated to manage lactic acidosis, as the liver cannot clear the lactate produced by peripheral tissues or the underlying pathology. What is the timing indication for CRRT in a patient who has just undergone cardiac surgery and is now on via ECMO? A. Wait until the creatinine doubles from baseline. B. Within 6 hours of a positive fluid balance greater than 5% of body weight. C. Only when the patient becomes oliguric, less than 0.5 milliliters per kilogram per hour. D. Once the patient is ready for decannulation. Answer: B. Within 6 hours of a positive fluid balance greater than 5% of body weight. Explanation. Post-cardiac surgery ECMO patients often benefit from early intervention. Many centers use a % fluid overload threshold, e.g., 5 to 10% above dry weight, rather than waiting for traditional renal failure markers. What is a specific indication for using a hemopurification filter, like Cytosorb, in line with the ECMO CRRT circuit? A. Severe hyperkalemia. B. Refractory hyperbilirubinemia or myoglobinuria. C. Low hemoglobin levels. D. High carbon dioxide levels. Answer: B. Refractory hyperbilirubinemia or myoglobinuria. Explanation. While standard hemofiltration removes small molecules, specialized sorbent filters connected to the CRRT/ECMO circuit are indicated for larger molecules like bilirubin or myoglobin, in rhabdomyolysis, to prevent pigment-induced kidney injury.